Very importantly, half of those patients being treated for type 2 diabetes do not meet HbA1c targets. And we know that prolonged increase in HbA1c has severe vascular complications, both macrovascular and microvascular. We also know that early tight glycemic control, achieving that HbA1c target as soon as possible, is vitally important to prevent those severe micro and macrovascular complications. It's important to initiate additional therapies to reduce HbA1c to achieve those HbA1c targets. We know that DPP-4 inhibitors effectively do this. Most oral therapies will reduce the HbA1c by about 1%. In one study with vildagliptin, there was a 1.1% reduction in HbA1c in addition to metformin compared to treating patients with metformin alone. A DPP-4 inhibitor is a possible second-line agent. These drugs are significantly safe. They are non-inferior to other agents, and very importantly, they're weight neutral. One of the most important assets of these drugs is the fact that they do not cause hypoglycemia. Many of the agents we use potentially cause hypoglycemia, and that causes a real issue, particularly if patients have renal complications. So hypoglycemia is very much minimised with these drugs. DPP-4 inhibitors as a second-line agent are ideal in our elderly population. They often have renal dysfunction as they age, as we all do, and they are extremely safe in this situation because they do not cause hypoglycemia. And even if patients do have renal dysfunction, we are able to dose reduce in all levels of CKD. We should not combine DPP-4 inhibitors with injectable GLP-1 agonists. There is no benefit here. They both work on the same pathway, and although hypoglycemia is not a problem with either drug, very importantly, they should not be used together. These days, when we're treating type 2 diabetes, it's all about combination therapies to get to the desired HbA1c target. Combining DPP-4 inhibitors with insulin treatments allow us to get to these targets without the added risk of hypoglycemia and weight gain, which often occurs with high-dose insulin therapies. Apart from hypersensitivity to DPP-4 inhibitors such as vildagliptin, there are no contraindications to these drugs. Common reported adverse reactions are headache, dizziness and tremor, but these are often transitory and self-limiting and do not require the cessation of the drug. DPP-4 inhibitors are very well tolerated. There is no increase in cardiovascular risk with the use of these agents. They can be used in patients with renal dysfunction, and there is a minimal risk of hypoglycemia. To achieve timely and sustained glycemic control, it is very important for GPs to monitor their type 2 diabetic patients. There is no doubt that regular HbA1c reductions, at least 3 monthly, until the target is achieved, is paramount. We now have a whole bevy of drugs that we have access to allow us to treat these patients. There is no doubt from the evidence that early tight glycemic control equates to good vascular outcomes, minimal microvascular and macrovascular complications.